Moving on to subscapularis, this is one that I think also goes hand in hand with any discussion of the lat, teres major, and long head of triceps. And certainly your subscap is maybe the last rotator cuff tendon that maybe doesn't get the love that it needs. It's just because it's harder to visualize. It's basically on the inside of the scapula, so it's between the shoulder blade and the rib cage, whereas most of the other cuff tendons are located on the opposite side of the joint. So what we see here is that subscapularis has a more proximal attachment. It's right on that humeral head. So while the lat may attach further down along with the teres major to create these gross movements and also the pec tendon, what we have here is we have a subscapularis that's a synergist to those muscles as an internal rotator, but what it does is it's very important arthrokinematically. So it controls that ball on the socket. So as people go through powerful internal rotation, whether it's throwing something or benching or whatever it may be, it makes sure that that ball stays centered on the socket while more of those gross movements are taking place. So it's an anterior stabilizer of the shoulder, really works to keep that ball centered on the socket. Internal rotation, yes, it does, but I'd say the thing about subscapularis is more often than not, it gets banged up. It needs more good quality soft tissue work in the area. And one of the things that we see is, if you see a subscapularis tear or, a high-grade partial tear or full thickness tear in a thrower, they tend to be very, very stubborn injuries because it's really hard for the other cuff tendons to pick up the slack for a subscap that's not doing its job because it has such a big cross-sectional area. It's really the one that's in the best position to directly compete with the pecs and the lats during kind of that acceleration phase of throwing. So subscap strains need to be managed, really, really conservatively and brought along slowly, get good manual therapy and things like that, rather than rush back because they do tend to be very challenging ones to rush back. And what you realize is from a pure anatomical standpoint is it's kind of like the posterior aspect of this shoulder where if you think about this, and we'll talk about this a lot more with the next stuff we get to later on, is you have all these nerve and vascular structures that run along down. They basically run between the clavicle and the first rib, past subclavius. They go right underneath pec minor, coracobrachialis, and short head of the biceps as they work their way here. So you have this big kind of neurovascular bundle that runs through here, and your subscap is on the back side, and it gets big hypertrophy and gritty. So what you can actually see is that subscap can kind of mechanically impinge on some of those nerve structures as they run through, and that's particularly the case if the cuff isn't doing its job. That humeral head is going to ride forward, kind of like jumping off your screen in this setup. And with a subscap that's gritty and poor humeral head control, all those nerve structures and vascular structures at the front of the shoulder are going to be much, much more exposed. So, it's working hard to counteract the pull of the pec major, the lat, the teres major as internal rotators. It's also a crucial decelerator as you lay your arm back, right? If you're going to fully external rotate, just like the lats, you're going to have to stretch that subscap, so it does have some force production capabilities. This is one that needs really, really good manual therapy in the right places. And if you look at some of the trigger point referral patterns, it can be sneaky. It can give you some of that inside of the arm type discomfort. It can almost present kind of like a subdeltoid bursa presentation up here. You'll get some stuff down by the wrist occasionally. It can give you a fair amount of posterior shoulder pain that may work down into the triceps as well, and certainly the opposite side of the hand. So subscap is sneaky. One of the things I will say about subscap, but there have been a couple instances over the years where if we backtrack and look at the anatomy here, we've seen someone who's had a thoracic outlet surgery. They've had a first rib removal. Maybe they'd have a scalenectomy, and they may even have had like a pec minor release to free things up. And all those nerves, by the nature of the surgery, should be gliding a lot better. And you'll still have someone that has distal symptoms further down. And in many cases, it's because the rehab didn't really take care of subscapularis. So you have someone that gets on the table, gets a little bit of, good pin and stretch technique or, manual therapy to that subscapularis, and it can be an absolute game changer. So I can think of 3 separate occasions over the years where someone had a thoracic outlet surgery and still had some kind of residual nerve symptoms that was responsive to good physical therapy / manual therapy of that subscap. So don't overlook it because it does not get the love it deserves. If we're looking at just how we train things, one of the drills I like to use is the prone internal rotation. And really all we're doing right here is we're talking about how to try to get true internal rotation of that humerus while keeping the ball centered on the socket and not substituting a scapular anterior tilt. So as we go through this exercise, the cue I'll give is imagine there's a rod that goes right through the elbow up to the shoulder. And all I want is I want you to basically rotate here. So it's almost like the biceps is a rotisserie chicken, and that internal rotation takes place without push into forward head posture, without that scapula dumping forward, or without a lot of up and down migration of that elbow. So it's just learning to kind of rotate smoothly. So the idea being we're not going to allow lat, pec, teres major, some of those powerful internal rotators to jerk the ball all over the socket. Instead, we're going to stay nice and centered as we internally rotate because the cuff is doing its job to keep this centered. I really like this a lot for people who may have gone through some manual therapy, at neck or posterior shoulder, positional breathing exercise, something that's transiently given them that improvement to internal rotation. And then we want to have something that follows up and just makes it stick in the right places. And this is a great exercise for doing that.